Hi, everyone. Welcome to today's Student-Led Journal Club seminar. My name is Dr. Staudinger. I'm Chair of Basic Science at KCU. Today, I'll be introducing student Dr. Nikki Barrington. This is her second time presenting, and if you haven't seen her first talk, I recommend you go ahead and watch that. As it was a great presentation about gender equality in neurosurgery. I will now put a link in the chat to that video if you care to peruse it. Please feel free to do that. Student Dr. Barrington is presenting to us through NERVE, a national neuroscience interest group. Specifically, NERVE stands for Neurosurgery Education and Research Virtual Interest Group. For students interested in neurology, you should know that they offer virtual opportunities for student doctors interested in specializing in neurosurgery. To learn more about NERVE, you can click on this link that I will put in the chat momentarily. We host a Canvas page for NERVE, and there's a good number of past presentations that you may peruse as well. So thank you again for coming to present, student Dr. Barrington. I'm going to do the formal introduction now. Our speaker, student Dr. Nikki Barrington, is an MD PhD student at Rosalind Franklin University of Medicine and Science. She received her Bachelor of Science from the University of California, Santa Barbara, and her Master's in Public Health from the University of California, Davis. She is currently completing her PhD in neuroscience, studying neuroinflammation in the context of traumatic brain injury, and plans to specialize in neurosurgery. Her research interests beyond traumatic brain injury include spinal cord injury, neuro-oncology, neurosurgical education, and training. As a med student, Nikki served as president of the Rosalind Franklin Student Interest Group in Neurosurgery. She's been a member of MSNTC's NERVE group during the 2021-22 academic year and is currently serving as junior director and journal club coordinator for NERVE. Student Dr. Barrington will be presenting on an article of interest entitled Pathological Computed Tomography, Features Associated with Adverse Outcomes After Mild Traumatic Brain Injury. Student Dr. Barrington, take it away.
Thank you so much for that great introduction, Dr. Staudinger. I appreciate it. As Dr. Staudinger mentioned, my name is Nikki Barrington, and I am currently an MD PhD student. And because my PhD research focuses on animal models of mild traumatic brain injury, I was particularly interested in this paper because I like to keep up with the clinical side of things while I'm getting my PhD largely in animal science. This paper was published in JAMA Neurology late last year, and it is entitled Pathological CT Features Associated with Adverse Outcomes After Mild Traumatic Brain Injury. And I will just go ahead and get started. So just a little bit of background to start off on mild traumatic brain injury. Mild traumatic brain injury is considered a Glasgow Coma scale or GSC score of 13 to 15. I'll show that a little bit more later, but within 30 minutes of post-injury. In addition to that score of 13 to 15, patients can also have a less than 30 minutes loss of consciousness, less than 24 hours of post-traumatic amnesia, impaired mental state at the time of the accident, and potentially transient neurologic deficits. So these are what we typically think of as sort of concussive injuries. And this particular study was specifically looking at complicated mild traumatic brain injury, which means there's a focal lesion present on CT. These complicated mild traumatic brain injuries are associated with worse outcomes for patients. The incidence of mild traumatic brain injury in the general population is about 200 to 300 per 1,000 persons per year. But those are patients that are hospitalized. So there are a greater number of patients that probably, makes this number underreported because many patients that have concussive injuries, be it in sports or otherwise, often don't go to the hospital and often don't get a CT scan unless they have some of these more severe presentations like what I talked about above. This particular study was a large longitudinal observational cohort of patients with mild TBI that reported to US level 1 trauma centers and had their outcomes measured at 2 weeks, as well as 3, 6, and 12 months post-injury, with the goal being to determine patterns of intracranial hemorrhage in MTBI and their implications for prognosis. Specifically, this study looked at sort of 2 different study populations, primarily the TRACK TBI cohort, which is the Transforming Research and Clinical Knowledge in TBI cohort. So there's 18 participating level 1 trauma centers for this study. The inclusion criteria include patients presenting within 24 hours of injury with a clinical indication for a head CT. Exclusion criteria include pregnancy, incarceration, non-survivable physical trauma, and pre-existing medical and neuropsychiatric conditions. They validated their results using the Center TBI cohort, which is an international cohort known as the Collaborative European Neurotrauma Effectiveness Research Group. Similarly, they have essentially the same inclusion and exclusion criteria, but in that cohort, there are actually 55 participating European trauma centers. So they have a few more participating groups than we have here in the US. For examining the CT results of these patients, they were looking at the National Institutes of Health, TBI, neuroimaging common data elements. So a positive CT was considered any acute intracranial abnormality on their first head CT after admission. They do not in this study include isolated skull fractures without an acute intracranial abnormality. And for the purposes of this study, they consider petechial hemorrhage as small subcortical or deep hemorrhages. So I'm going to give a few examples of what those look like. So examples of the types of things that we're seeing on CT in these patients include epidural hematoma. The yellow arrows show that sort of lenticular shape that we know to be associated with epidural hematomas, as well as subdural hematomas, contusion, and subarachnoid hemorrhage, intraventricular hemorrhage, and petechial hemorrhage. So those are all sort of classic examples of what they were potentially looking for on these patient CTs. In terms of measuring the outcomes for these patients following head injury, they actually used the extended Glasgow outcome scale, which is a little bit different from the traditional Glasgow Coma scale. I'll show you that in a second. This scale is more intended to measure global functional outcome post-TBI. The way that they administered it was slightly different in the TRACK TBI cohort versus the Center TBI cohort. The TRACK TBI cohort, they administered with the intent of really capturing disability associated with TBI. But in general, the scale itself is largely the same. So just to give you an idea of what that scale looks like, this is the Glasgow outcome scale, which instead of going from up to 15, like the traditional just Coma scale, this goes up to 8, with 8 being good recovery and below 5 essentially being moderate to severe disability. The way that they evaluate this outcome scale is through a structured interview. I'll show you a few of those questions that really have to do with how well the patients can function following the head injury. So can they obey simple commands? How much independence do they have at home relative to how independent they were before the injury? How much help they need at home? And how independent patients are outside of the home. Can they shop, travel, etc., with or without assistance? And how debilitated they are in terms of their ability to work, if they are able to work with restrictions or not able to work at all. And then sort of the last element of this is more of the social and family activities. So how much have their social and leisure activities been affected by their TBI? How restricted are they? And similarly with family and friendships, are there psychological consequences that have resulted in disruption of their previous relationships with family and friends and their ability to participate in those activities? And lastly, kind of a return to normal life relative to how independent and how functional they were before the injury. So all of these things kind of go together into that extended Glasgow outcome scale to get a score for the patients. To contrast this, because most people are more familiar with just the Glasgow Coma scale, these are the things that they're looking for to get that score that was 13 to 15, so a different score that classifies these injuries as mild traumatic brain injuries as opposed to moderate to severe. So this is more of a physical exam related scale. So how well patients do with responding to stimuli, how oriented they are on physical exam, and their motor responses. So how well can they obey commands, withdraw in response to pain, etc. And then again, based on the points that patients get from the previous slide, they are classified into a Glasgow Coma scale score. As we said, 13 to 15. That third one down there is considered mild head injury, and anything less than that is considered moderate or severe. So that's where the patients come from, but in terms of how they do when they leave the hospital, we're looking at that other scale that focuses more on how independent those patients are after the fact. And then lastly, before we get into the results, just a little bit about their analysis methods. So they used hierarchical cluster analysis and multiple correspondence analysis to kind of look at, to identify clusters of phenotypes seen on CT in these mild TBI patients. And they also used a generalized estimating equation model to associate various factors about these patients, specifically their demographics, clinical features, and their CT features with either incomplete recovery, so an outcome score of less than 8, or a greater degree of unfavorable outcomes defined as an outcome score of less than 5. And again, they looked at that at 2 weeks, 3 months, 6 months, and 12 months post-injury. So next, to get into the results, first they showed what the demographics of this particular patient population was. This is the track TBI cohort, which I'm going to focus primarily on because the center TBI cohort was primarily used for validation of the results. They ended up with just over 1,900 patients being eligible for track TBI, and they had outcome measures available for just about 1,500 of those patients. As you can see here from the red box, most of the patients were men, and a positive head CT was actually more likely in men in this cohort. A positive head CT was actually less likely in Black individuals in terms of the racial demographics. And the most common clinical care pathway, meaning what happens to the patient after they come into the hospital, was hospital care without an intensive care admission. So they get admitted to the floor, but they don't necessarily have to go to the ICU. Next, a positive head CT was more likely in individuals with higher education levels, which we can see here at the bottom, that bottom red box, and also more likely in participants without a history of prior traumatic brain injury, which we can see from these significant p-values in the boxes that I've created there. What's probably a little bit more interesting in those demographics is the clusters of CT findings that they identify here. So I'm going to go into this in more detail. Specifically this graph, it's called an upset plot. I had to learn how to read these before I could explain this to you. But essentially all of the potential CT findings are listed on the bottom here, and any of the circles that are colored in are the ones that are found in that particular column, and how common they are is represented in the bar graph above. So in this first column here, for example, subarachnoid hemorrhage was the most common finding amongst this cohort, and as you can see from the significant bar graph size over the top. Second to that was a combination of subarachnoid, subdural, and contusion. Again, you can see how common that was in the bar graph above. So they had quite a variety of different clinical findings, but the most common was isolated subarachnoid hemorrhage. As I said, combined subarachnoid, subdural hematoma, and contusion. Isolated subdural hematoma was the third most common. And lastly, combined subarachnoid and subdural hematoma. This part of the figure gives us an idea of how often these findings occurred overall, not necessarily in combination with each other, but specifically looking at how common these things were. So subarachnoid hemorrhage and subdural hematoma were the most common in this cohort. And then moving on to their hierarchical cluster analysis, essentially the height of these lines indicates how closely related these things are, or how likely they are to occur together. So as we saw with that upset plot, the subarachnoid hemorrhage, subdural hematoma, and contusion are much more likely or much more often frequently found together, as are intraventricular hemorrhage and petechial hemorrhage. And then lastly, epidural hematoma is kind of the least most common that we see. And moving on to the center TBI results, they essentially recapitulated the track TBI results very closely. So as you can see, the demographics were also overall very similar. Most, again, were men and had similar care pathways, getting admitted to the hospital, but not to the ICU. Overall, this cohort had a higher incidence of positive CT findings than the track TBI cohort. And the sort of order of frequencies was a little bit different, but like track TBI, isolated subarachnoid was the most common, followed by combined subarachnoid, subdural, and contusion. But overall, the top 4 patterns found in that track TBI cohort were within the top 5 patterns in the center TBI cohort. And the hierarchical cluster analysis revealed the same sort of groups as you can see here. 3 clusters with the subdural, subarachnoid, and contusion together, interventricular and petechial together, and lastly, epidural. So moving on to how these different findings were actually associated with outcomes in the study. First of all, female sex, as you can see in that first highlighted box there, neuropsychiatric history and prior TBI were associated with incomplete recovery, but not greater degrees of unfavorable outcomes. So they were associated with a score of less than 8, but not with a score of less than 5. So those are potential risk factors for patients for incomplete recovery. Age and fewer years of education, as you can see in those boxes, were associated with incomplete recovery and greater degrees of unfavorable outcomes, so a score of less than 5. Again, you can see that here. So that was significant on both a score of less than 8 and a score of less than 5. And in terms of the CT phenotypes that I just talked about, that contusion, subarachnoid, and subdural hematoma cluster was significantly associated with both incomplete recovery and greater degrees of unfavorable outcomes at all time points. So having any of these findings, particularly in combination on CT, suggests that patients, even with mild TBI, will have poorer outcomes across the board, even at 1 year after the injury. Again, this is showing that it was also associated with unfavorable outcomes or a score of less than 5. And then moving on to some of those other phenotypes. For the epidural hematoma phenotype, it was associated only with incomplete recovery at some of these earlier time points, but overall, these patients seem to do better. And then lastly, interventricular and petechial hemorrhage were associated with greater degrees of unfavorable outcomes only at some of these later time points, which again is not great news for patients. So generally, other than epidural hematoma, these patients tend to not do very well. In terms of sort of controlling for some of the variability in this study, there were 41 patients who underwent decompressive hemicraniectomy, 21 of which was for epidural hematoma. When those were excluded from the cohort, the odds ratios that are seen here changed minimally, so that probably didn't affect the outcomes too much. And other studies have shown that patients that come in with a Glasgow Coma score of 13 as opposed to a 14 or 15 tend to have worse prognoses than those with higher scores. They also removed the patients with a GCS score of 13 from the cohort, and they found that that didn't change the model very much either. So in both the track TBI cohort and the center TBI cohort, the contusion, subarachnoid, and subdural CT phenotype showed significant associations with incomplete recovery and greater degrees of unfavorable outcomes up to 1 year after injury. And similarly, the interventricular hemorrhage and petechial hemorrhage group was associated with greater levels of unfavorable outcomes in both studies up to a year. The center TBI and track TBI cohorts found that epidural hematoma was associated with incomplete recovery at a year. and in one study and 3 months in the other study, but generally not associated with greater levels of unfavorable outcomes at any point in either study. So it seems like those, other than epidural hematomas, possibly maybe because those patients tend to get decompressive surgery, and potentially that helps with better outcomes. Unclear, but for whatever reason, those patients tend to do better than the patients that present with other CT phenotypes. So just to discuss these findings a little bit, less than 50% of mild TBI patients and 39% of patients that have mild TBI with these positive CT findings even get follow-up care. So clearly there is sort of something to be desired in the healthcare system in general for how we follow up with these patients, and in particular not being dismissive of these mild TBI patients as, okay, you just got a concussion, go home, don't sleep. That kind of traditional guidance that patients often get may not encompass the full picture. Previous studies have found that CT characteristics were not associated with improvement. To be more specific, they didn't improve prognostic ability relative to demographic and clinical characteristics alone. So some other studies have found that looking at these CT characteristics is not helpful, but a lot of those studies are a bit older, and our CT technology has improved drastically over the past decade. So we're able to look at these things with a greater level of granularity than we did in the past. And in this particular study, the population was enriched for those complicated MTBI patients, meaning the patients that have positive CT findings. So that kind of allowed the study to dive deeper and figure out which of these characteristics is associated with worse outcomes. So we as providers can figure out who is going to need greater follow-up care. And they also speculate that some of these CT phenotypes can provide information on the mechanism of injury. Specifically, the patients that have that sort of subarachnoid and subdural hematoma presentation likely have a linear acceleration or deceleration mechanism, while the other types like the intraventricular and petechial hemorrhage category probably represent a more of a rotational injury. And so that can also, being able to dive deeper into these different CT characteristics can kind of give us an idea of how these injuries are occurring in these patients. And again, help us to help them better in terms of their long-term recovery. Some limitations of this study, the patients that didn't necessarily get follow-up throughout the entire 1-year time period, there was a group that was lost to follow-up, and those patients may have a different distribution of outcomes. So there's kind of not a great way to account for that. Similarly, the intraventricular hemorrhage and petechial hemorrhage was associated with incomplete recovery in one cohort, but not the other. However, as I mentioned at the beginning, the center TBI cohort had 55 contributing level 1 trauma centers. So that study overall was higher powered due to a larger sample size and a higher rate of positive CT findings. So that could explain some of the discrepancy there. Another sort of interesting finding or inconsistent finding was that history of prior TBI was actually found to have a protective association in the center TBI cohort, and instead was associated with incomplete recovery in the track TBI cohort. And this could be due to how prior TBI was assessed in these two different cohorts. In the center TBI cohort, they had a series of short questions regarding medical history. And those of us that work with patients know that just asking open-ended questions about medical history in general is not always going to elicit a prior head injury, particularly if it was a concussive injury and the patient didn't really realize how potentially serious that can be. It may not come up in a typical patient interview. Whereas in the track TBI cohort, they had a standardized procedure for eliciting a lifetime history of prior TBI with a structured interview. So the track TBI study probably captured more prior TBI events. But overall, as we saw, those two groups were very similar to each other in terms of the associations of the outcomes, the demographics, and the different clusters of CT findings there. So altogether, it's a pretty high-powered study. there's sort of traditional wisdom in the people that study TBI, people that work with TBI patients, that moderate and severe TBI outcomes are determined by what the injury brings to the patient. So in other words, how serious the injury is really dictates the outcome. And the patient doesn't have as much control over it, so to speak. Whereas mild TBI is traditionally taught to be what the patient brings to the injury. So more the demographic factors, the internal factors having to do with the patients themselves kind of dictate how the patients recover from these injuries. But this study is really showing that there's variability in prognosis for these different hemorrhage types, and that mild TBI outcomes can be dictated by what the injury is bringing to the patient, that there is a certain level of granularity there, depending on what type of hemorrhage or other CT findings are associated with that particular injury, even within that 13 to 15 Glasgow Coma scale score. And so we probably need to be triaging patients appropriately. And in particular, as I mentioned, that statistic about only 50% of these mild TBI patients, or less than 50%, getting follow-up care really demonstrates sort of a gap in the healthcare system with regard to following up with those patients, not just with their physicians, but in an interprofessional way with social workers and various other healthcare professionals that can really help them navigate the potential deficits that they may have after getting an injury like this. And with that, specifically, patients that have contusion, subarachnoid, subdural, intraventricular, or petechial hemorrhage, so really any CT finding other than epidural, can be associated with adverse outcomes across the Glasgow extended scale scores up to 1 year after MTBI. So we really need to be paying attention to those CT results and following up with those patients accordingly. Those are my references. And with that, I will take any questions.
Okay, the floor is open. I have the microphone at present, so I get to do something here. First of all, I want to thank you, Nikki Barrington, for representing NERVE and coming to this forum twice now. As a reward, I've put your flyer in the chat, and anybody who wants to save it can double click on it and download it to your desktop. The other thing I'm going to do is kind of ask a question, I reckon. It's an analogy in a way with cardiology. Historically, cardiologists thought that post-MI and post-open heart or CABG, grafting new arteries on your heart, you were supposed to just lay in bed and recover. Whereas the paradigm was challenged in Texas by the DeBakey Center. No, you're supposed to get up and move around as quickly as possible. So the question I'm getting to is there any role that exercise can play in mild or even severe traumatic brain injury?
I definitely think so. I think overall lifestyle in general is a big part of recovery after any kind of traumatic event, but in neurorehabilitation in particular, it's kind of in my mind, a use it or lose it type of thing, both intellectually and physically. So I think both of those things come into play. It's kind of been shown, for example, totally unrelated to TBI, but potentially related because multiple TBIs can actually lead to dementia. Education level has been shown to be protective against things like dementia. And so people that are not necessarily directly having higher education, but people that are engaging their brains, people that are taking care of their bodies are likely to do better in a neurorehabilitation setting than other patients. So I think in terms of the follow-up care, like I said, it's about giving patients access to resources to do those things to help with their own recovery.
Yeah. So on the other hand, with respect to my ignorance, you need to inform me. Are there programs specifically designed that will engage TBI patients mentally in a regimented, structured way that is covered by insurance?
I don't know about covered by insurance, but I am currently working with she's actually a physical therapist by training, on an article about non-invasive electrophysiological interventions for patients following TBI. So essentially outside of the body, like percutaneous stimulation, scalp stimulation or skull stimulation. I'm sure people have seen kind of pictures of things like this. While patients are doing activities to engage neural pathways for learning and memory and things like that, can actually really help with neurorehabilitation following TBI. So I know programs like that exist, particularly for veterans as a significant population that experiences TBI. As far as covered by insurance for the average person, I don't know, but there are definitely programs that exist to help patients in a more an interprofessional, taking into account all of their life circumstances kind of way.
Okay, the last thing I'll do is just congratulate you on occupying the rarefied air of it being an MD PhD candidate. And from my perspective, I predict success. Your career trajectory is just, you deserve everything good that's coming your way. You've earned it.
Thank you, Dr. Stottinger.
You're welcome.
And if anybody's interested in NERVE or MSNTC related opportunities, feel free to contact me. I just wanted to throw that out there for the students.
You got it. Ivan, I see you have a question. Go ahead.
Yeah, listening to this study kind of reminds me of a study that was done in 2018 looking at the use of repeat CT scans on CT verified mild TBIs. And I'm not sure if this study looked at the repeat series of the CTs and if there was any progression of TBI associated with that. I know that the 2018 study found very minimal progression on patients, but I wanted to see if they saw that there.
To my knowledge, I believe they just looked at the one sort of snapshot after the patients were initially admitted. But particularly they referenced several patients in the cohort that got a decompressive hemicraniectomy. And so definitely those patients from a neurosurgical perspective would have gotten serial CTs to make sure that the epidural hematoma resolved. So they're probably, the data is there to look at that, but I don't think this particular study did. But I think that would be interesting.
Thank you, Ivan. Brandon G., go ahead.
Hey, Nikki, thank you for presenting this topic. This was certainly my first time reading about such a topic. I have a question about tables 1 and table 2. Mm-hmm. Table 1, I think it was age and years of education that were positively associated with positive CT findings. Mm-hmm. Then, however, if you go to table 2, and if I'm interpreting this correctly, at least the effect of education, it seems to turn.
Yeah, I'm trying to find the right slide. Bear with me for 1 second.
The author didn't do a great job specifying which one was. Yeah. I guess the authors didn't do a great job of specifying what the reference group was. Was it the 12 years?
Yeah, I believe so. I think it was the lower level of education was associated with incomplete recovery, but they specifically say 16 versus 12, which is a kind of an odd way to, I assume that it's basically high school education versus a college education based on the number of years there. But obviously there's some people that may have had some years in between there, but I believe what they're getting at is that a higher level of education is going to be protective and helpful in recovery, kind of like what I was saying about patients that engage those neural pathways more often. It's usually protective against neurodegeneration to a degree.
Okay, great. That's an interesting finding, I think. And I guess the second question and last question is, do you know if they tested any interaction effects to tease out those individual effects?
I don't believe so. They did have some supplemental findings that I got into a little bit, but I don't think they did.
Okay, thank you. I appreciate it.
Thanks.
Andrew, go ahead.
Yeah, I guess I was just wondering, maybe for just clarification's sake, if you could reiterate why you use the extended Glasgow scale as opposed to just like the regular one.
Yeah, so The Glasgow Coma scale, so the traditional, it's confusing because they basically have the same name, but the traditional Glasgow Coma scale is more of a clinical assessment of how well or how poorly the patient is doing when they come into the hospital. And so that kind of gives you an idea of how severe the injury is. The extended scale is more outcomes oriented. So kind of, I think of it as, you know, what do they look like when they come in? That's what that Glasgow Coma scale, the, you know, 0 to 15 or 1 to 15 is. And then the Glasgow outcome scale, the extended version, is really focused on the outcomes and how do the patients do after they leave the hospital. So I feel like they should probably rename them with 2 different names. It's confusing. But one is more clinically at the hospital oriented and one is more discharge oriented.
Great, thanks.
Also, nice
Brian.
to see you after emailing.
For sure, yeah, for sure.
Go ahead, Brian.
Hi, Nikki. So I had a question based on, you had said at the beginning there was a difference in the amount of participants in terms of sex that were enrolled, and then you noticed a significant effect in the amount of sex in table 2. So I wanted your interpretation. Oh, you were just on it, table 2.
Oh, sorry.
No, you're good.
Too many tables.
I wanted,
yeah,
too many tables. I wanted to know if you thought that that was like an actual effect or maybe a cause of them sampling too many men versus women.
Potentially. So yeah, there's, as you're pointing out, there's potentially a confounder there because there's more men than women in the study, but also from what I understand from a public health perspective, men overall tend to do activities that get their heads injured more than women do, and tend to participate in activities that might result in more severe injuries as well. So they may be more likely to show up with these CT findings because overall, even within the spectrum of mild TBI, men may tend to have worse injuries than women, possibly just as a result of the activities that they're engaging in that result in the head injury. I don't know if there's a real finding in terms of like, for, you know, there being a biological reason for men to have worse head injuries. I think it's probably more of a circumstantial thing.
Okay. All right. Thanks.
Quick comment. There's a reason they call those motorcycles donor mobiles.
Yes. Yes.
The liver usually survives.
Yeah, and I will say, for those of you that live in states with no helmet laws, you should definitely wear a helmet anyway. And if you ever spend any time in a neuro ICU, you'll see exactly what I'm talking about.
So you're not an advocate of let those who ride decide.
I think there are safe ways to ride motorcycles,
Sure.
and a lot of people don't take advantage of things that could make it more safe.
I came to my senses and sold mine at age 58, I think. Ivan, go ahead.
Nikki, did the authors provide a length of stay for those patients that were admitted to the floors? I think that'd be important to look at, just to, you know, if they have more support and stuff, they could have a better recovery.
Yeah, they didn't actually look at that, but I completely agree with you. Length of stay is an important factor in kind of, I mean, obviously patients that are more well tend to get discharged sooner, but there is something to be said for not rushing to discharge and allowing some of those other teams that are in the hospital and resources that are in the hospital, whether they be physical therapists or social workers or what have you, work with those patients more, or even potentially having, when there's more severe head injury, typically patients are discharged to like a rehabilitation facility and they're worked with for longer. And so I think maybe not to that same scale that we see with moderate and severe TBI, but there probably is a role for some kind of maybe even outpatient rehabilitation programs for some of these mild TBI patients to make sure they're actually getting the care that they need.
Yeah, and I'm sorry, on the same note, I think, you know, with discharge documentation, providing proper instructions would also be a good
yeah, absolutely
thing to look at.
Yeah, completely agree.
So I see my colleague, Dr. Dennis Wolf, has a question. Dennis, go ahead.
Yeah, thanks. I enjoyed this. I was curious with respect to the age and like college students and stuff like that. And clearly as people get older, you get stronger if you're engaging in sports. So it's easier to damage things. And so I was curious to what extent perhaps better equipment in the college game contributed to a possible benefit, or to what extent having super female athletes engaging in sports and that could also impact how much damage there might be. So those were things I thought about in relation to education and just, as you're trying to get out there and look at things like that.
Yeah.
Go ahead if you wanted to comment on that. I don't know that there was really.
Yeah. I mean, I think that the awareness that's come about in terms of the public awareness of things like chronic traumatic encephalopathy in relation to college and professional football and things like that has really started to change the landscape a little bit in terms of, as you mentioned, better equipment, but also more appropriate aftercare when athletes get concussions, keeping them out of the game for longer than we used to, things like that. And I know, maybe the athletes hate it, but the data probably shows that is helpful.
And they've even altered the rules. So trying to reduce the number of devastating hits that occur in the sport of football.
So my other question related again to ignorance, but many years ago when I taught pathophysiology to nursing students, there was the concept of coup and contre-coup and diffuse axonal injury. And so I was curious to what extent any of those things contributed. And then you also mentioned rotational injury. And I'm assuming there's the same type of thing going on there as there is with linear injury. So whether or not to what extent those things impacted. I mean, I have no idea. Can CT detect diffuse axonal injury, and at what scale can it detect it? Can it detect 10% or along those lines?
Yeah, I couldn't give you necessarily a specific number. I'm not well versed enough in CT, but I certainly think that they even mentioned diffuse axonal injury when they were talking about mechanisms of injury and how definitely with the advanced nature of CT relative to even 10 years ago, we definitely have a better idea of when that's occurring. And I imagine that will only get better as time goes on. But to your comment about the coup contra coup injury, at least in the animal models that I work with, that has definitely been borne out in the sense that pathological proteins associated with neurodegeneration can definitely be found on the opposite side of the brain, even when we do these mild TBIs on the other side. I work with mouse models, and so I think that's very much also held true in clinical studies of patients. So the sort of long-term pathological proteins and the associated cognitive decline can definitely take place over a long period of time, and the sort of coup contra coup injury has a role to play in that.
Thank you so much, Dr. Wolf. Brandon G., I see you have a comment in the chat. Would you like to unmute and address that question?
Sure, yeah, I was just asking, seems like the variance, at least variance explained in tables 2 and 3, was only about 11 and 10%, something like that. I pulled the paper and thus I was very curious. But what other variables or what other biological markers or relationships do you think might explain some of the remaining variance?
Ooh, that is a good question. I think that I am not well versed in at least the basic science on this, but there are groups that are kind of studying, for lack of better words, almost like brain resilience and reserves. And so there may be actual biological factors that are associated with patients that tend to improve quicker or overall just improve more than others. And so I guess that does kind of tap into that, use it or lose it. Maybe it depends on education level or the way that you use your brain, or maybe there is a genetic sort of biological link where certain patients are more resistant to brain damage or better able to heal following brain damage than others. But I also think there's always something to be said for, which they didn't really necessarily, they talk about race here, but socioeconomic factors and access to healthcare, access to follow-up, all of these things is, as with many diseases, going to kind of dictate a large degree of the outcomes. And so I think it's also important to consider some of those factors that this study didn't really look at, but many others have, in terms of how the socioeconomics of different groups impacts their ability to follow up and get the care they need, and simply to live a higher quality life following an injury such as this.
I think those are hypotheses. Thanks.
Sorry to interrupt. I think, I think it's good to look at, I mean, for me, the age of 55 versus 26, the fact that it was only a 1.17 ratio increase. I thought, the older population would take longer to heal, but it doesn't seem by much. So age is not really a protective factor, or much of a protective factor.
Yeah, exactly.
Interesting.
Yeah, that is definitely interesting. I'm not sure what would account for that. Normally, as with many diseases, age tends to just make everything worse. But as you noted, it wasn't actually that much worse in this study. So again, maybe there's other factors that play a role here that really need to be looked at in both basic and clinical science in the future.
Any other questions? Okay, point of interest in the chat, I've dropped the Journal Club full schedule. You can double click on that and download it, and I encourage you to come back. This was a well attended, and you've stimulated a lot of good discussion, student Dr. Barrington. So I appreciate everyone's involvement. Spread the word. And if there's anything of specific interest moving forward, please reach out. We're here to support everything.
We will be having a NERVE member present pretty much every month for the entire academic year. I'm pretty sure it's pretty much the last Journal Club of every month. But I definitely, if I know there's some people in here that are in NERVE, encourage you guys to participate in that and encourage attendance for those presentations, as well as all the other ones.
And we're happy to provide, if you're a little uncomfortable with public speaking or Zoom or PowerPoint, where we provide coaching as well during the week of your presentation. So without further ado, everybody have a great Friday. Take care.
Thank you. Have a good weekend.
Thank you, everybody.